Hello, everyone, and welcome. In this clinical explainer, we're going to tackle a really critical choice we make in trauma surgery. For those intertrochanteric fractures we treat with a cephalomedullary nail, which is better, the helical blade or the lag screw? Now, this debate has been going on for years, but some really powerful recent evidence is starting to give us some clearer answers. So let's dive into the data.
Here's how we'll break it down. We're going to start with the basic biomechanics, then climb the evidence pyramid from randomized trials all the way up to some massive real-world registry data. Then we'll uncover a really critical nuance that has to do with patient health. And finally, we'll pull it all together into some clear, actionable takeaways for our day-to-day practice.
For decades, our main goal has been pretty simple: get stable fixation so we can get our elderly patients up and moving fast. And while the cephalomedullary nail is, the proven workhorse for these fractures, the debate over which implant to put in the femoral head, blade, or screw is still very much alive.
So this is the big question, right? Is one of these devices just flat out superior across the board? Or does the answer change depending on the fracture, the quality of the bone, or maybe even the patient themselves? To figure that out, let's start with how they're designed. These two implants are really built on different philosophies. The helical blade, on one hand, is designed to compact that spongy, cancellous bone as you put it in. The theory is that this gives you better rotational stability. The lag screw, on the other hand, relies on that classic, time-tested principle of threads biting into the bone for its pull-out strength. So two very different strategies for the same problem. The real question is, how do they stack up in the clinic?
Let's start at the top of the evidence hierarchy with randomized controlled trials. A pretty recent meta-analysis gives us an excellent high-level view of what's going on.
Okay, now what's really striking here is the consistency. When you look at the data from over 1,100 patients across 11 different randomized trials, Huang and Wei found, no statistically significant difference in the outcomes we care about most. Things like mechanical failure, functional outcomes like the Harris Hip score, or even post-op pain. Just look at those p-values, all well above that 0.05 threshold. So the big takeaway from the highest level of evidence seems to be they're basically equivalent. But is that the whole story?
Not quite. While the major complication rates look pretty similar, other RCTs, like this one from Kumar and Srivastava, point to a whole different set of advantages. What they found was that the helical blade was tied to significantly shorter surgery times, less blood loss during the operation, and fewer fluoro shots. Now, these are not small things, right? In a busy trauma center, and especially for our frail patients, these kinds of efficiencies are really clinically meaningful.
So the RCTs are telling us they're pretty much equal on major failures, but the blade might be more efficient in the OR. Let's see if that holds up when we move from the controlled world of trials to massive, real-world data from a huge patient registry.
And when I say massive, I really mean it. This recent study from Okike and colleagues looked at over 22,000 cases. A number that big gives us incredible statistical power to see even tiny differences in how these implants perform.
So the first big conclusion from all this registry data, it actually backs up what the meta-analysis told us. When you just look at the entire population as a whole, there's no overall difference in the risk of aseptic revision. The adjusted hazard ratio was 0.87, but the confidence interval crossed 1 with a p-value of 0.27. So on the surface, it looks like the story of equivalence still holds. But this study allowed them to dig a lot deeper.
And this, for me, is where the analysis gets really insightful. The investigators asked a crucial question. Is the implant's effect the same for every patient? And this brings us to the statistical concept of effect modification.
Think about it. If both implants are generally the same, does that mean it truly doesn't matter which one we pick for our healthy, active 70-year-old compared to our frail, multi-comorbidity 95-year-old? Well, the data suggests it just might.
So just a quick refresher, especially for our trainees in the audience, effect modification is basically when the relationship between two things, in our case implant type and revision risk, actually changes depending on a third factor. And in this study, that modifying factor was the patient's overall health, which they measured using the ASA classification. And here it is. This is the crucial finding. When the authors split the patients by their ASA score, a really clear picture emerged. Look at the sicker patients, the ASA 3s and above, which is most of our hip fracture population. For them, the implants performed identically. The hazard ratio is 1.03, basically no difference. However, in that healthier group of ASA 1 and 2 patients,
the helical blade was associated with a statistically significant 35% lower risk of aseptic revision, and you can see the p-value there is 0.04. This is a huge finding and a major step forward in this whole debate.
Okay, so what does all of this mean for us on a Monday morning in the operating room? Let's try and synthesize all this evidence, from the basic biomechanics to the RCTs to this powerful registry data, and turn it into a clear plan for the clinic.
All right, first takeaway. For most of our patients, the sicker, more frail folks who are ASA 3 or higher, the evidence is pretty clear that both implants are going to perform equally well. Second, we can't just ignore that operative efficiency data. Helical blades seem to have an edge in OR time, blood loss, and radiation, which could be a real benefit in this frail group. Third, and this is the big update for our practice, for our healthier, more active geriatric patients, those ASA 1s and 2s, this new evidence suggests a real significant advantage for the helical blade in lowering the risk of aseptic revision. And finally, a point that's always true but bears repeating, technique is king. No fancy implant design is going to save a bad reduction or poor placement.
So this leaves us with a final, really critical thought. Maybe the question was never which implant is better, but instead, which implant is better for this specific patient sitting in front of me? This evidence strongly suggests we should be shifting away from a one-size-fits-all approach and moving toward a more nuanced, more evidence-based, and patient-specific way of choosing our implants. Thank you.